Hello, my name is Christian Barton from La Trobe University in Melbourne. I'd like to first start by acknowledging the traditional owners of the land on which I'm coming from you today, the Wurundjeri people, and pay my respect to the elders past and present. I also want to say a special thanks to the Conference Organising Committee for inviting me to present to you today on implementing appropriate first-line care for knee osteoarthritis, and in particular some of the work I've been doing with a very large team here at La Trobe and across the country in Australia related to GLA Australia. So today we're going to talk about what is first-line care for osteoarthritis. We're going to also talk about a little bit how BMI might influence what we do with people in front of us with osteoarthritis. Talk about the barriers to first-line care. Also thinking about some of our experiences related to not only outcomes, but also thinking about ongoing barriers and facilitators to GLAD within Australia. So if we start with guideline recommended care for osteoarthritis, and these are consistent with guidelines all across the world, what we commonly see in recommendations is that education, exercise and weight control or weight management should be provided to all people with hip and knee osteoarthritis. And this is regardless of pain severity, demographics and radiographic severity. Second line care can be considered, so these are things that physiotherapists might implement, like different manual therapy techniques, taping, also thinking about pharmacology and thinking about pain modifying medications, injections, etc. And then as the last line of treatment, we can think about surgery, and in particular joint replacement surgery for those with end-stage disease. What's important about considering guidelines here is that at no stage of the second or third line care replace or override first line care. So the idea is we always provide first line care and optimise that, and that's a really important concept that we want to talk about today. So if we look to the evidence of supporting these guideline recommendations, we can see from a recent systematic review led by Anthony Goff, who's a PhD student I have the pleasure of working with at La Trobe University, looking at patient education. There's a number of studies that have looked at this. Most studies look at patient education as a control intervention, but there are some that do compare it to usual care. And what we see in the short term is that it does produce superior outcomes to usual care when we look at things like pain and functional outcomes. The important note here, though, although it might be statistically significant, many of the findings here are not considered clinically meaningful. So we would recommend, based on this, although it's superior, it may not be something to consider as a standalone treatment. If you put patient education head to head with exercise therapy, so this is exercise programming delivered typically by a physiotherapist, we often see that we get inferior outcomes for pain and function. But what about if we combine education and exercise together? Well, what we can see from our systematic review, which is open access and you can all read, is that in the short term, we see superior outcomes for pain. We also see superior outcomes for function, and these superior outcomes for function carry over to the medium term as well. So combining exercise therapy and patient education is going to be better than either intervention alone, and particularly better than patient education alone. What you'll notice, though, is that we see similar outcomes for both pain and function in the longer term. So that initial hit of exercise therapy with a health professional certainly does have its benefits, but the effects of that may wash out over time. And that's something we need to consider when we're providing healthcare to individuals with osteoarthritis and really any persistent musculoskeletal condition and other arthritic conditions. If we look at the evidence for exercise, there is a much larger, compelling case for exercise. And so what we see here is a graph produced by Carsten Jell, a researcher from Denmark. And I'll just orientate you to that graph a little bit. If we have a look at the forest plot, we can see effect sizes here. So you notice there's quite wide confidence intervals, looking at exercise being more beneficial compared to a control intervention. As we go down the line here, what we can see is that the effect sizes seem to stay relatively consistent, favouring exercise. So this is a pooling of each study. So the first plot here would be just the first study. The second plot would be a combined data set of the first and second study, combined data set of the first, second and third, combined of the first, second, third and fourth, etc. And you'll notice that the confidence intervals get smaller and smaller and smaller as we go down, and the variation or the change with each particular line gets less and less, and we become very, very confident that there's a moderate effect of exercise therapy compared to control when we're managing people with knee osteoarthritis. So when we look at this data in a little bit more detail, not only do we know that it's beneficial, and this is regardless of the type of exercise therapy, so aerobic, resistance training, neuromuscular exercise, but we probably didn't need to do any more randomized controlled trials since around 2002. So what we can see that when we got to 2002, there was enough evidence that would indicate that exercise therapy is something that should be implemented. So we probably haven't needed to continue doing these randomized controlled trials over the coming years. If we look at cost-effective analysis, so this is looking at the benefits of providing the care, so of course there's a cost to providing exercise therapy. Does that have a benefit to the health system and more broadly the economy? And it certainly is cost-effective compared to usual care and written advice when we look at a couple of studies from both New Zealand and also from Denmark. So those promoting exercise therapy can not only promote the clinical benefits of it, but it's also a highly cost-effective intervention as well. So implementation principles, we don't have a long time to go over this within a lecture like this, but we can certainly discuss this more later. What are the key things that come out of the literature of how we should implement exercise for people with hip and knee osteoarthritis? We wrote 7 key recommendations as part of a paper that we put together in JOSPT a couple of years ago. So myself and Soren Skoo, who's a founder of GLAD, along with a couple of other researchers from around the world. And based on the evidence, what we can see is that we get better outcomes if we tailor target to individual needs and preferences. Aquatic exercise is a really valuable option for people who can't complete land-based exercise in people with osteoarthritis, but land-based typically produces better outcomes. There's a minimum dosage required of exercise, which is a really important concept for people to remember. So only doing a few sessions of exercise or doing it for a couple of weeks and not doing very long sessions is unlikely to lead to benefits. We typically see a minimum of 6 weeks as required before almost all people are likely to see the benefits. And not only 6 weeks, but a minimum of 2 sessions a week. If we can get people to do 1 to 2 extra sessions a week, so 3 or 4 sessions, that's likely to improve outcomes. And if we can extend their program from 6 weeks through until 12 weeks, that's also likely to benefit their outcomes as well. The other consideration that we could contemplate is booster sessions, and there is evidence that would suggest that that improves adherence and can also improve outcomes, and it's particularly important for us to progress exercise programs. And we talked before about perhaps the benefits of combining education and exercise washing out over time. Booster sessions can certainly help to address that. And then we also need to really importantly think about how we address the barriers to exercise participation. So education and reassurance about managing pain flares, also education and reassurance about inflammation, and the safety and benefits of exercise is really important to optimize outcomes as well. So what about body mass index and thinking about weight, and does that need to modify how we prescribe exercise? I often get people who are fearful of doing exercise because they're overweight, and clinicians seem to drive this belief as well that perhaps we should be really cautious of weight-bearing exercise because someone's got extra load on their joints. I just want to flag a really nice and neat trial from Kim Bernal and Rana Hinman and their group at University of Melbourne, where they actually looked at an exercise therapy program in obese population. So you can see the average BMI for the 2 groups, around 37. Their 2 interventions that they compared or put head to head were a non-weight bearing exercise program, and this was typically open chain quadriceps exercises, and then they also put together a weight bearing exercise program. So they had some lunging or sliding exercises, they had some wall sits, they also had some crab walks, they had some step ups and step downs, and some really very similar exercises to what we use within the GLAD program, which I'll talk about shortly. What were the outcomes? Well, they saw similar within group changes to other NEOA cohorts. So even in this more obese population, they still saw really positive changes and improvements with an exercise therapy program. There was no difference between the 2 groups in pain or function, and that was measured by WOMAC at 12 weeks. And contrary to what we often think, is actually the weight-bearing group did better than did the non-weight bearing group in this obese population. So they had better improvements in quality of life. So no difference in pain and function, but better improvements in quality of life in the weight bearing group. So I think we can start to put that to bed a little bit, that we should be avoiding weight bearing exercise or avoiding exercise at all in people who are overweight, and that's an important consideration. Some people have the contemplation, well, if someone is obese or overweight, do we start with exercise or do we start with weight loss? And so this is always an interesting consideration. It probably comes down to the individual and what their needs and wants and desires are, but certainly starting with exercise is a feasible thing to do, as we've talked about. If we have a look at some more broader literature, and I really like this paper by Gasser and Gardi, who look at whether or not it's going to be more important to maintain a normal weight or more important to maintain fitness. And what you'll see on the graph here is some hazard ratios. So if we look at a hazard ratio for all-cause mortality, so 1 being someone normal weight, you can see in the red here, as someone increases their weight, so goes to overweight, we can see the hazard ratio increases a little bit and increases a little bit further, and we see the same trend for cardiovascular disease mortality. If we have a look at the blue here, which is the unfit group compared to the fit group, so what we can see here is that when you've got an unfit group, it really increases your hazard ratio compared to a fit group for mortality, and that's consistent across normal weight, overweight, and obese. So if we ask the question a different way, are you better off being fat and fit, or better off being skinny or normal weight and unfit? You're definitely better off being what we consider fat and fit. So if we look at that, this is what we could consider the fat and fit group. So an obese population who's considered fit and their mortality hazard ratio, compared to someone who's got normal weight but is actually unfit and their mortality hazard ratio. So starting with exercise is a really sensible option for this population for many reasons, well beyond the benefits of pain and function, but also thinking about general health benefits of getting someone physically active again. So it should be a no-brainer that if someone turns up to a GP, that they should be referring them for exercise support, perhaps considering pharmacology relief and sending very few people for surgery based on what we know about the evidence. And guidelines typically recommend not to refer for imaging for this population. So I ask you the question, what do you think typically happens in a GP setting in Australia? Well, if we look at the data from a large data set called the BEACH data set recently published, what we can see is that imaging referral for hip and knee osteoarthritis occurs 25 to 31% of the time, so pretty high. If we look at surgical referral, we see that between 13 and 16% of people are referred for surgical opinion. If we look at pharmacology, we see close to 1/4 are prescribed things like opioids. So actually 26% of people with hip OA are prescribed an opioid medication, much higher for recommendations for things like paracetamol. And how many are referred for exercise support to an exercise physiologist or a physiotherapist? Well, it sits at about 5%. So currently in our healthcare setting in Australia, very few people are given support for exercise and physical activity. You're much more likely to be prescribed opioids or sent to see the surgeon, and far more likely to be referred for imaging. So we wanted to understand the barriers to why more people weren't referred for exercise and weren't referred for physiotherapy, and we wanted to start to look at what that might be in terms of the work capacity of physiotherapists. So as part of our GLAD program, we've been surveying physios for a number of years along with a lot of qualitative research, and I'll just share some of our data from that, which was recently published. This is looking at the COMBI model, which is a way you can consider barriers and enablers for implementing an intervention. And we look at capability, opportunity, and also motivation. So you'll see the green indicates that physiotherapists we surveyed strongly agree or agree, and red would be strongly disagree, and you've sort of got your orange and yellow in the middle. If I highlight a couple of the findings in terms of opportunity, you'll see that a lot of physiotherapists, in fact, around about a third believe the don't believe the organisation they work at has all the resources they need to deliver exercise and education to people with osteoarthritis following clinical practice guidelines. If we look at other things, their capability, and do they believe they've been trained? So if you look at the top here, I've been trained in delivering exercise education, you'll see that actually less than half agree that that's the case. And then when we look at managing perhaps the unmotivated patient, which can be a lot of the patients we see, again, around half don't believe that they've got the confidence in order to provide education and exercise therapy to those individuals. So really highlights a need that we need better resourcing in organisations, but also training and education of physios in order to help them to deliver interventions that are required. Interesting stat or finding from this data set of more than 1,000 physios is that 11% are able to name an accepted guideline for osteoarthritis management. I wouldn't take that as a criticism for physiotherapists. I don't think they help us all that much in terms of implementing what we should be in practice, because they're very long and dry documents without a lot of how-to guidance. It probably is more a function of guidelines being inappropriate for actually changing clinical practice, and maybe more important for researchers and their CVs. So the question is, when we talk to GPs, why don't you refer more people to physio? It's often because they're not sure that they're going to be delivered high value physio. So they're not sure that they're going to be delivered education and exercise, and then there's a whole range of different other barriers like funding to support that care as well. So one of the things we really need to make sure that we do is ensure that when patients do get to physios is that high value care is delivered. So this is what led us as a research team to GLAD, which stands for Good Living with Osteoarthritis from Denmark. You can learn more about the program on the website, so the GLAD Australia website, and can certainly send out links after this session so you can look at that. So what is GLAD? Well, GLAD contains 3 core elements. So the first element provides physiotherapists with education, training and support to deliver a guideline-based program. So the program involves 2 education sessions and 12 exercise therapy sessions. The second, and they're all delivered group and they're all supervised. The second component of GLAD is they go back to their clinics and they deliver that intervention as intended. So that's really important, and they tailor it to each individual patient, to their needs and their goals. And we promote GLAD as being a minimal intervention, so you can add treatments to that program, and it's also a framework. So if you need to modify the exercise program to suit individual needs, you can certainly go ahead and you can do that. The third element of GLAD, which is really, really important, is it also facilitates data collection of patient outcomes. So we make sure that we're collecting and evaluating outcome measures related to the program. So ultimately, we want to try and optimise the implementation of first-line care in physiotherapy practice. What we don't cover is weight management, but that's something that we encourage physios to refer to dietitians, etc. So it's a really big team, so I'll just make some acknowledgements to Professor Eva Roos and Professor Søren Skue, who established the program in Denmark and are the founders. My mentor, Professor Kay Crosley, who has really encouraged our team, and then Jo Kemp, who you'll see in the middle here on the left. She's been the co-lead of the program since 2016 when we started it together. And then we have some great research assistants, Matt Francis and Karen Dunjules, and we have a team of postdocs now that we're starting to develop. Alongside that group, we also have around 25 tutors from all around Australia. And as a result of the work of, or hard work of many, many people, we've managed to train approximately 2,000 physiotherapists to deliver the program, and it's now available in more than 500 sites across Australia. So I think it's been a real implementation success story, but importantly, not just getting the program implemented, we also have that capacity to evaluate outcomes. So what do we do within GLAD? Well, the first thing we do is provide the patient education, as I mentioned before, and the key thing we're trying to encourage with that is to change the message that people have in their heads about what osteoarthritis is. So we try and shift away from that concept of bone on bone and wear and tear and degeneration and start to get patients to think about the many different modifiable factors that might influence their pain and their disability. So we're trying to change their treatment focus away from thinking about structural damage to thinking about things they can target with exercise and lifestyle. And so we want to put them in charge, get them to focus on self-management, think about sleep, think about diet, think about exercise and physical activity, think about how pain catastrophization and fear of damage might be influencing their symptoms and engagement in exercise, and try and change that behaviour. So that's something that's a supported process both through the education sessions, so there's 2 of them that go for an hour, but also the 12 supervised exercise therapy sessions. The exercise program involves a range of exercises which target resistance training, so trying to improve the capacity of the knee extensors and flexors, hip abductors.
Stand
and
weight bearing on one leg with the other leg on a
exercises
sliding surface.
step-ups,
Slide backwards
sit-to-stands,
to forwards with the
whole range of
sliding leg
activities like that.
whilst
We also have
flexing
some
and extending the
exercises
knee
that
of the
target
weight bearing
confidence and
leg.
using sliders, and
Ensure
I'll just
you are
share
keeping good alignment of the shoulder, hip, knee and foot. To perform this on carpet, you may use a slide pad, which can be purchased from your physiotherapist. To progress this exercise, you can reduce the amount of upper limb support, increase the repetitions, increase the speed of the movement, or take a longer slide. If you find your knee falling inside of the foot, it helps to contract your hip muscles to rotate the knee outwards.
You may use a slide pad, which can be purchased from your physiotherapist. To progress this exercise, you can reduce the amount of upper limb support, increase the repetitions, increase the speed of the movement, or take a longer slide. If you find your knee falling inside of the foot, it helps to contract your hip muscles to rotate the knee outwards.
So that's an example of an exercise to try and build confidence. And it's really a great one if someone's had a history of quite severe pain and they're really struggling for confidence in loading their joint, their hip or knee or potentially ankle even. It's a really great exercise, but as I said, there's many others. And if you want to learn more about the specifics of the exercise program, there's a website here that's open source, open access. You can go to nemex.trekeducation.org, and many of the exercises and the progressions, etc. are on that. So it's freely available if people want to have a play with it. So what are our outcomes in Australia? We've seen some really good outcomes both in hip and knee. We recently published our program evaluation for knee osteoarthritis outcomes. This was across the first couple of thousand patients. And just to share some of those findings, we saw 3 in 4 people engaging with the program reported clinically meaningful improvements in pain or quality of life at not just 3-month follow-up, but 12-month follow-up. We also see a large proportion, or largest proportion, of around 1 in 2 people desiring surgery before they start GLAD. And when we look at this population specifically, 3/4 of them, when we get to 12 months, haven't had surgery, and they no longer desire surgery as well. So really good outcomes in perhaps changing the pathway of treatment and perhaps reducing the burden on the healthcare system. And these types of outcomes are probably going to be really important as we move out of the pandemic as well. So something to consider. We do have data on medications, and I don't have the specific stats here, but it does seem to reduce pain medications. And similarly to other research in terms of looking at things like BMI and other comorbidities, we do see similar outcomes or similar improvements in populations with more comorbidities or higher BMI. So the program stands to benefit really anyone that's got hip or joint related pain with their primary diagnosis or being clinical diagnosis of osteoarthritis. If we look at that a little bit deeper, and some of our program evaluation looks at why more Australians with osteoarthritis don't access GLAD, and the key themes that come out is there really is a lack of funding from private health insurers, so they don't support group education as an example. There's no coding for that. The funding for group exercise is really limited, and patients are still left with a lot of out-of-pocket costs. There is no Medicare support for group-based care for osteoarthritis. So there is some for diabetes from the Medicare system, but for chronic disease more broadly, there is no group-based care items that we can use, and we're really limited to the EPC, so the 5 sessions, and that really isn't adequate for programs like GLAD. So we really need to improve our public healthcare funding. The other thing is that most Australians and most health professionals are really not aware of the benefits of exercise therapy. So this comes from not only surveys and qualitative research with physios, but also doing similar work with GPs, rheumatologists and surgeons, and following that up with patients. And most people aren't aware of the benefits of exercise. And in fact, many see exercise as being a potential harmful intervention when we know that's not true. And as we know from talking before, that GPs are more likely to refer for things like surgical opinion or prescribe things like opioids. So this is something we really need to work at a health system level if we're to improve access. We have the data there in the osteoarthritis space to show that across the country and across many healthcare settings, there's benefits to the program. Now we just need to improve access to the program. So my take homes from this little presentation: exercise therapy and education are cost effective and key first line physiotherapy care. High BMI does not seem to be a barrier to engage in exercise. In fact, it probably makes it more important, considering the health benefits of exercise and physical activity has the potential to counteract some of the health detriments of having a higher BMI. There are lots of good quality patient education resources we have available on the GLAD website, which you can get, and there's also some other resources we're developing which I can share links to. But the key for us is to really try and address misinformation, which is often the key to getting people to participate in exercise. So getting away from the thought process of pain being related to damage, those concepts of wear and tear, and focusing on bone arthritis, and thinking about all the modifiable factors that someone can change. So exercise therapy really should be targeted and adequately dosed, and the importance of doing that and getting adequate dose is clear in the literature and also clear in our outcomes from GLAD. And I guess on reflection, one of the things that I'm really pleased about to see is that GLAD is now improving thousands of lives in Australia, and we hope it to continue improving thousands and thousands more lives. It's perhaps the most rewarding project or piece of research that we've ever done, but also the most complicated and challenging as well, and I'm looking forward to questions about it later. So thanks very much for listening.